Okay, hello, my name's Sam. Can you tell me your name and date of birth, please?
Lindsay, the 8th of the 12th, 1993.
Cool, okay. So what I'm going to be doing today is going to be performing a respiratory assessment on you. So I'm going to be standing at the end of the chair here and just inspect you first, then I'm going to move in and inspect your chest, your hands, head and neck, and then also have a listen to your lung sounds. Is that okay?
Yeah.
Cool, okay. Could you take your shirt off for me, please? Okay, so first I'm going to stand here and just observe you. So I'm looking at the patient. Do you have any shortness of breath or pain anywhere first?
No.
No, okay. So I'm looking at the patient. Do they in any shortness of breath at all? Do they have any nasal flaring or accessory muscle use, which can suggest they've got the shortness of breath is of respiratory origin? I'm looking at their respiratory rate. Should be between about 12 to 20 in a normal adult. I'm looking at their skin colour. Do they have good perfusion? Is the skin colour normal pink? Is it mottled or blue grey, which can suggest hypoxia? Could you count to 10 for me, please?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Cool, okay, so I'm just seeing what their words per breath are. Something like only 1 to 2 words per breath can suggest they're in quite severe respiratory distress, making them very sick. So it's a good way to look at how sick a patient may be. I'm also looking around the bedside environment, what there is around. Are there any medications, something like asthma or an asthma inhaler or GTN, and oxygen bottles maybe suggest they have chronic obstructive respiratory disease. I'm looking, do they have any mobility aids like a walking stick or wheelchair or anything like that. Now I'm going to inspect your head and neck. Is that okay?
Yeah.
Yeah, okay. Could you please pull your eyelids down for me, please? Thank you. So I'm just looking whether there is any pallor or discoloration which can suggest anemia. Yep, that's fine. You can put them up. I'm looking at the patient's lips, whether they have got blue lips, which can suggest hypoxia. May have something like chronic obstructive respiratory disease, chronic bronchitis. I'm looking whether the patient's breathing through pursed lips, whether their lips are red, can suggest they might have emphysema. Okay, could you put your head to the side, please? I'm just looking whether they have any jugular venous distension, can suggest they've got an increased intrathoracic pressure from something like a cardiac tamponade or pulmonary embolism or cardiogenic pulmonary edema. Okay, so I'm having a look at the chest now. So I'm having a look if there's equal chest rise as she's breathing. Are there any scars anywhere which could suggest a previous surgery? So a unilateral chest rise can maybe suggest a pneumothorax. I'm also looking for if there's any trauma or any recent trauma that she's had on her chest. Okay, can you put your hands out for me, please? So I'm looking for the colour of the hands, so whether there's any peripheral vascular disease, and maybe mottled, cyanode skin. I'm going to feel the warmth of each one, so it should be equally warm. I'm also going to just squeeze your finger, okay? So I'm going to test the capillary refill, so squeeze the finger, and then the colour should return within 2 seconds. Okay, so that's good. Could you place your fingers together like this for me, please? So I'm just looking whether the nails have got a curve in them, which can suggest clubbing, which is clubbing, which can suggest a chronic hypoxia, which can be seen in chronic obstructive respiratory disease. Okay, now I'm just going to, could you place your hands out again? I'm also just looking for any tremors in the hand which can suggest asthma inhaler use, and also can you place them up like this? Any tremors like this may suggest a hyperventilation syndrome. Okay, I'm just going to feel of your pulse. So I'm feeling the rate and regularity of the pulse, and on the other side as well, it should be the same. Yep. So now I'm just going to feel your chest, so I'm just going to palpate it, and I want you to take a big deep breath. Is that okay?
Yeah.
Okay. So I'm going to place my hands on your chest here and take a big deep breath. And just feeling for equal chest rise. So a unilateral chest rise may suggest a pneumothorax. I'm also feeling the ribs here for any crepitus. Any sore anywhere? No, nothing yet. Which may also cause a pneumothorax. There's no pain while you're breathing in or anything?
No.
No, okay. I'm also, while I'm feeling for any lumps or any masses or tenderness. I'm also feeling for any subcutaneous emphysema, which can be indicative of a pneumothorax. Okay, so I'm just going to feel the pulse in your neck now, okay? So I'm just feeling the carotid pulse on the neck. You're feeling for rate and regularity. That feels normal. Cool, that's good. Okay, I'm going to listen to your lungs now, is that okay?
Yeah.
Okay, I just want you to take big deep breaths while I place the stethoscope over your chest. So I'm listening for the volume and quality of air entry in all lung fields. I'm listening for any abnormal sounds, such as wheezing, which can suggest asthma or cord. I'm listening for any crackles or rattles, which can suggest pulmonary edema. I'm also listening for any absent lung sounds, which may suggest a pneumothorax. I'm also listening for any stridor, which is a high-pitched noise, which may suggest a upper airway obstruction. And on the side. Cool, thanks. I would also listen to the back as well. Okay, now what I'm going to do is I'm going to listen to your chest again, and I want you to say 99 each time I press the stethoscope on your chest, okay?
Okay.
So this is just testing the vocal resonance.
99, 99, 99, 99, 99, 99.
So any increase in volume can be suggestive of a lung tumour or increase in density in the lungs. I'm going to percuss your chest, is that okay?
Yeah.
Okay, I'm just going to press up here. So I'm listening for changes in resonance in the lungs. So any dullness or dull resonance can suggest fluid in the lungs or tissue density, which may be a hemothorax or a tumour. We're listening to any hyperresonance, which could suggest a air in the pleural space, which would be a pneumothorax. So we just want to do all the lung fields. Cool, that's good. And there you go, we're all finished now, so you may place your top back on. Thank you. Okay, so after respiratory assessment, there will be different aspects of assessment which may indicate different levels of patient acuity. So for example, if the patient was found to have an obstructed airway at the beginning, this would be a status 1 and may need immediate intervention. Along with severe respiratory distress, such as only 1 or 2 words per breath, and also severe accessory muscle use would also be status 1. A patient with moderate respiratory distress, such as only 4 words per breath, moderate accessory muscle use, not significant hypoxia would be status 2. A status 3 patient would be someone with mild respiratory distress, for example, someone with a wheeze on auscultation, no hypoxia, a mild increase in respiration rate, but is able to respond to bronchodilators. Okay. Hello, how are you going? My name's Sam. Can you tell me your name and date of birth, please?
Lindsay, the 8th of the 12th, 1993.
Okay. So what I'm going to be doing today is performing a cardiovascular assessment on you. So it's just going to include examining you first, and then inspecting your chest, and then having a listen to your heart. Is that okay?
Yeah.
Cool. Okay then, could you take your shirt off for me, please?
Yeah.
Okay, so first, are you in any pain anywhere?
No.
No? And no chest pain or anything like that?
No.
No? Okay, so any chest pain may increase your suspicion for something like acute coronary syndrome or myocardial infarction. Okay, so first of all, I'm just going to have a look around you. So I'm looking for, at the bedside environment, are there any medications around, something like GTN or aspirin? Is there any oxygen, maybe they have immobility items, so a walking stick or wheelchair. Do they have any cigarettes around? Someone who's a smoker and will have increased risk of cardiovascular disease. Okay, so are you comfortable at rest?
Yes.
Yes. Okay, it doesn't look like the patient's in any pain at rest there. It doesn't look like they're in any discomfort. I'm looking at the colour and perfusion of their skin. So this patient has got good colour. If they were pale or diaphoretic, could also suggest acute coronary syndrome. Someone who's pale, cyanosed, mottled can suggest hypoxia. Also anyone that has flush skin with rashes anywhere can also suggest anaphylaxis. Okay, so I'm looking at the patient's breathing. Doesn't look like they're any shortness of breath. I'm looking at their rest rate. Is it the depth? Is it shallow? Looking for equal chest rise or any pain while they're breathing. And do you have any shortness of breath lying down?
No.
No? Okay, so shortness of breath lying down can suggest pulmonary edema. So especially people with CHF can have this. So if the patient has any chest pain, I want to first find out the onset of the chest pain. Does it radiate anywhere? Is it provoked by anything? Is there anything that makes it better? What's the severity of the pain? And also the quality of the pain. So what type of pain is it? Is it crushing, aching, that sort of thing? Okay, now I'm going to inspect your neck. Is that okay?
Yeah.
Could you place your head to the side, please? I'm looking for any increased jugular venous distension. Jugular venous distension. This can be caused by an increase in intrathoracic pressure, which may be caused by something like cardiogenic pulmonary edema or also cardiac tamponade. Alright, so I'm just going to have an inspect your chest now, is that okay?
Yeah.
So I'm looking for any scars anywhere on the chest, maybe from previous surgery. For example, a scar just underneath the clavicle here could be a pacemaker. I'm looking for any visible pulsations, especially under the fifth intercostal muscle here, as you may be able to see the apex of the heart, which can be caused by hypertrophy of the heart. Okay, I'm just going to have a look at your abdomen now, okay?
Mm-hmm.
So I'm looking for any visible masses, visible pulsating masses. This can be caused by a AAA or a abdominal aortic aneurysm. And this is a medical emergency, can cause hypovolemia. Do you have any abdominal pain at all?
No.
No? Okay. I'm looking for any discolorations on the abdomen, especially any discoloration down here underneath the umbilicus, which is called the Cullen sign. This is indicative of a bleeding in the peritoneal cavity. So this can be caused by something like an ectopic pregnancy, which can also cause hypovolemia and is another medical emergency. Also looking for any distension of the chest or ascites, which can be caused by right ventricular failure. Okay, I'm just going to have a look at your legs now, okay? Could you take your socks off for me, please?
Yeah.
Okay, so I'm comparing the legs. I'm looking for any scars, any discoloration, or hair loss, which maybe can suggest peripheral vascular disease. I'm looking at the ankles down here, if there's any swelling or edema, which can be caused by congestive heart failure. I'm just going to feel the pedal pulses. If I can feel a pedal pulse on each foot. Yep. And are you able to wiggle your toes for me? We've got full movement in their feet. I'm feeling the temperature of each foot, so the equal temperature. Also the coloration, so anything that's pale, cyanosed can be caused by hypoxia. I'm going to just squeeze your toe, looking for the capillary refill, which should be less than 2 seconds. And I'm also looking for any muscle atrophy, which can also be caused by peripheral vascular disease. Okay, now I'm just going to have a look at your hands now as well. You place your hands up for me, and I'm just checking for any discolorations. Again, peripheral vascular disease, any change in temperature, they're both nice and warm, and some hands that are mottled or blue colour can be caused by hypoxia. Again, I'm going to take your capillary refill. Should be less than 2 seconds. Anything more can be caused by vasoconstriction. Maybe they're compensating for something else. And could you place your fingers together again as well? So looking for any clubbing of the fingers, which can be caused by chronic obstructive respiratory disease or a chronic hypoxia. Okay, I'm now going to take some of your pulses. Is that okay?
Yeah.
Yeah, okay. So first I'll get your hand out and feel your radial pulse. So I'm assessing for the rate and the rhythm. I'm feeling if it's irregular, which can suggest a heart arrhythmia. I'm also going to compare on the other side. It should be the same. If I'm unable to feel the pulse, it may mean their blood pressure is below 80 systolic. Okay. Also, I'm just going to feel the pulse in your neck. Is that okay?
Mm-hmm.
I'm going to feel the carotid pulse here. I'm assessing the volume and character of the pulse. A slow rising carotid pulse may mean aortic stenosis. Cool, feels good. Now I'm just going to take your blood pressure as well. So I'll take the blood pressure. Normally in a normal adult, a blood pressure should be about 120/80. Anything lower than that can mean can be indicative of shock. Maybe going to decompensated shock. High blood pressure will also increase the risk of cardiovascular disease. We also want to look at the difference in pulse pressure. So wide pulse pressure may mean, I've forgotten, but narrow pulse pressure can be someone who has a traumatic brain injury or aortic stenosis. Okay, I'm just going to have a look at your back now. Is that okay? You lean forward. I'm just looking for any sacroedema, which can be caused by right ventricular failure. I'm going to listen to your heart sounds now. Is that okay?
Yeah.
Okay. So first I want to listen to the aortic valve, which is the second intercostal on the sternal edge. So I'm listening for the opening and closing of the valve. A dysfunction in this, you may hear a gushing or whooshing sound. So pulmonary valve, second intercostal, left sternal side. Listening for the same. Now I'm listening for the tricuspid valve, which is the fifth intercostal, the left side of the sternum. And the mitral valve on the fifth intercostal and the midclavicular line. Cool, that sounds good. And now I'm just going to listen to the base of your lungs. So if you could move forward for me, please. I'll listen on your back. So I want to listen for any crackles or rails. So take a big deep breath in. So you're listening for any pulmonary edema, which can be from left ventricular heart failure, and it's usually in the base of the lung, as that's where the water sits due to gravity. Okay, and we're all done now. You can place your shirt back on. Thank you. So after a cardiovascular assessment, the level of cardiovascular compromise will determine the patient's status and acuity. So for example, someone in severe decompensated shock will have lowered blood pressure, mottled skin, poor perfusion, and shortness of breath, also beginning to decrease in heart rate. That would be status 1. Or someone with a dysrhythmia causing severe cardiovascular compromise would be also status 1. A status 2 patient would be someone who has a dysrhythmia with a mild cardiovascular compromise, or someone with myocardial ischemia who's pale, cool, diaphoretic, has chest pain, and which is not resolved after nitrates. A status 3 patient may be someone with myocardial ischemia, which is resolved after nitrates. So hi, my name's Sam. Can you tell me your name and date of birth, please?
Unless Lindsay, the 8th of the 12th, 1993.
Okay. So in this examination, I'm going to be conducting a neurological assessment. So we're going to be looking at your brain function. So is that okay?
Yeah.
Yep. So before we start, you don't have any pain anywhere or anything?
No.
No? Okay. So I'm just going to stand here first and get the general appearance. Alright, so I'm going to be looking around the bed. Is there any mobility aids such as wheelchair, walking stick, any medications around, anything like that? I'm going to look at the patient's posture. Are they sitting upright? Are they swaying at all? May suggest they've got some neurological disorder. Looking at the patient's appearance, their skin colour, any signs of neglect or any abnormalities may need further examination. Also, I'm just going to ask you a few questions. Do you know where you are today?
Yes.
Can you tell me what day it is?
It's the 12th today.
12. And you said yes, you know where you are. Where is that?
At my parents' house.
Okay. And can you tell me your address?
My address, 7 by 118 Vauxhall Road.
Cool. Okay, so they're orientated to time, place and person, so this is an important assessment in any brain injury or concussion. Now is, could you get up and I'll just watch you walk to the end of the room, please?
Yeah.
So I'm just watching her stance. I'm seeing if she's swaying while she's walking at all, she's got any difficulty moving any limbs. This can be caused by a cerebellar dysfunction. Okay, now what I want you to do is I want you to walk with your heel to your toes like this. Yep. So I'm looking if she's got any difficulty doing that, any swaying. So this can be also done in a concussion test. Okay, cool, that's good. And now could I get you to stand with your, stand over here with your feet together and your hands by your side, and I want you to close your eyes. So I'm watching whether she's swaying as she's standing there. So this can also be done in a concussion test. This is also testing her cerebellar function. Cool. Yeah. You can sit down now. Okay, so now I'm going to assess your speech. So could you repeat after me? Can you please say hippopotamus?
Hippopotamus.
And can you say the sun is shining in Cincinnati?
The sun is shining in
Cincinnati.
Cincinnati.
And British Constitution.
British Constitution.
Cool. So I'm just listening for any syllables that she's not able to pronounce or any slurs in her speech. This test is normally done in a fast test, so assessing for a stroke. So someone with a stroke may have changes in their speech and unable to say some syllables and have disturbance in their speech. Okay, so now what I'm going to do, I have a look at your eyes. So what I want you to do is to follow my finger. Yeah, that's good. Up, down, and to the middle. Cross-eye. Yeah. Okay, so I'm looking for any involuntary eye movement. So both eyes are moving together, and also looking for any shaking of the eyes. So this is done in someone who has a stroke may have these symptoms or other neurological disorders. And I'll also be looking for, just going to shine this in your eyes. So I'm just looking whether the pupils are equal and reactive to light. So we want to assess this in a brain injury. So someone who's had a knock to the head, we want to see if their pupils are equal and reactive. Also in drugs, someone taking an opiate may have constricted pupils. Now I'm going to assess your arm movement. So can you place your arms out like this with your palms up and close your eyes. And so I want to watch the arms for 20 seconds. So I'm watching for any downward drifting of one arm. So this can be done in a fast test also. So someone with a stroke will have their arm drift down on one side. Cool, that's good. So now I want you to squeeze my hands. So I'm looking for any weakness of one hand, and I want you to pull on my hands too. Yep. So any weaknesses in one arm. And do you have any funny feelings in your hands or anything like that?
No.
And also want to assess the feeling as well. So if you close your eyes, can you tell me where I'm feeling?
Yeah, in my elbow, forearm,
Over here.
and fingers.
Which arm?
Right.
Cool. And so this is assessing the myotones of the spinal cord, so you can do this with someone with a spinal injury. So they may have changes in sensation or also loss of function of the arms or hands. Okay, so now I'm going to test the rebound phenomenon of your arms. So I want you to place your arms out like this, and I'm going to press down them, and I want you to return them to their normal space. Yep, that's good. So in a positive, you can place your arms down now. So a positive test in this is the arms would shoot upwards past where they were, and this is a sign of cerebellum disease. Alright, so now we're going to assess the tone of your arms. So I just want you to place your arm out of here, and I'm just going to move it in all movements. Yeah. So I'm just feeling for any increased tone of each arm. So it should just be floppy and move quite easily. So someone may be having a seizure or something, you'd be able to feel an increased tone in a tonic seizure. Also, in late stage neuron damage of a spinal cord, you may also feel increased tone in the arms. Assess your coordination. So what I'm going to do is I'm going to put my finger up here, and I want you to get your finger in place, finger and nose like this. Yeah, that's good. Cool, that's good. So someone, you can do this test with someone with a concussion. They may not be able to do this. It's also indicative of a cerebellar disease as well. Okay, so now what we're going to do is assess the tone of your legs too. So I'm just going to do the same as your arms and check all the movement of the legs. So any increased tone in the legs can also mean a tonic seizure, or also a late stage spinal injury. Cool, and now what I'll get you to do is place your hands out like this, on top of each other, and I'll get you to place your hands like that. And I want you to do that as fast as you can. Cool, that's good. So this is testing cerebellar ataxia. So normally a patient who has this, then they will not be able to do that. They won't have, they'll have a lack of voluntary coordination. Okay, so now I'm going to test your reflexes in your legs. Is that okay?
Yeah.
Alright, so I just want you to keep your legs floppy there. I'm just going to hit here. Cool, that's good. So we're looking for the reflexes. They should be, as soon as we hit it, should shoot up. A decreased reflex could be suggestive of a spinal injury affecting the myotones. Also, I'm just going to take this sock off here too. Both feet. And we'll do an ankle one. Yep. Cool. And now what I'm going to do, I'm just going to run this along the bottom of your foot. So this is called a Babinski reflex. So you run it on the lateral side underneath, and the toes should dorsiflex, and they have, so that's normal sign. In someone with a spinal injury, you may see a positive Babinski reflex where the toes will dorsiflex and fan out. Cool, okay, so we're all done. Thank you. So common findings in neurological assessment can be a stroke, seizure, headache, traumatic brain injury, concussion, or a spinal injury. Each will change the patient's status and acuity. So for example, someone with a TBI and inability to obey commands would be status 1. A spinal cord injury with neurological deficits would be considered status 2. As well as a stroke with someone who has face unilateral weakness in their arms, or disrupted speech. If these symptoms are within 3.5 hours of onset, they'd be status 2 and need immediate transport for thrombolizing to hospital. Someone with a headache, normal neurological findings, may just be a status 4 and may not need transport to hospital.